My name is Ashley Mitchell, and I am here today to discuss with you all perinatal mood and anxiety disorders with a focus on postpartum depression. What is PMAD? It's perinatal mood and anxiety disorders. This is depression or anxiety that can happen during pregnancy or after having a baby. During the postpartum period, about 85% of birthing people can experience some type of mood disturbance. And most symptoms are mild and short-lived. However, up to 15 to 20% of birthing people develop more significant symptoms of depression or anxiety. There are three categories. The first is baby blues, which is really common. Most postpartum individuals will experience this within the first 2 to 3 days after giving birth, and it lasts about 10 days. Feelings of fatigue, weepiness, very emotional time, and it usually gets better on its own. Postpartum depression and anxiety affects about 20% of postpartum individuals and even up to 10% of men or support people. So this interferes with one's ability to take care of themselves or their baby, and it's accompanied with intense feelings of sadness, anxiety, and hopelessness. And this can occur up to a year after giving birth, and it usually requires treatment. The next category is postpartum psychosis, which affects 1 to 2 per 1,000 postpartum individuals, usually affecting those with history of mental illness, typically occurring within 4 weeks after giving birth, and it's associated with hearing things that others cannot, extreme agitation, restlessness, manic episodes, confusion, paranoia, mood swings, and thoughts of harming oneself or their baby. And postpartum psychosis is considered an emergency. Postpartum depression is considered a significant patient safety issue and is linked to maternal and infant morbidity and mortality. During the first year after giving birth, postpartum individuals are more likely than any other time in their life to develop a severe mental health disorder. There are a lot of emotional changes that occur during the postpartum period, a lot having to do with hormone changes within the body. Unfortunately, there are negative impacts on both the postpartum person and the baby. This includes affecting bonding. It can delay the baby's cognitive development. Postpartum individuals who are dealing with postpartum depression are less likely to breastfeed, and there is increased risk for future socio-emotional problems and violent behaviors in the children of these patients. And there's an increased risk of childhood mental illness. As we talked about, this can affect anywhere from 15 to 20% of birthing people. And of that percentage, 19% of them go on to express ideations of self-harm. And researchers believe that postpartum depression and anxiety is the most common complication after pregnancy. And this can occur over some time gradually, or it can happen very suddenly. The prevalence of postpartum depression is extremely common, affecting about 1 out of every 8 postpartum individuals. We do know that racial and ethnic disparities can contribute to higher rates of postpartum depression due to the lack of socioeconomic support, lack of access to care, health insurance, mistrust in healthcare professionals, exposure to adverse childhood events or ACEs, and of course, stigmas related to mental health. Other things that are common in those who are experiencing postpartum depression are those who are younger than 19 years old, and then another group being the age of 20 to 24 years old. Those with less than 12 years education, non-Hispanic, Black, American Indian, Asian, Pacific Islander population, those that are considered single, non-married status, even if they are living with their support person or significant other, those who are on Medicaid at delivery, who have smoked cigarettes during their pregnancy, breastfed for less than 8 weeks, those who have experienced any sort of intimate partner violence during their pregnancy, that can be physical, verbal, or emotional violence, and of course those who have experienced a fetal demise. Other risk factors for developing postpartum depression include having a history of depression or anxiety, a family history of depression or anxiety, those who have had a difficult pregnancy or birth experience, especially like a traumatic birth experience, those who have given birth to multiples or who had preterm infants who are in the NICU, those who are experiencing problems in their relationship or with their partner, any other stressful life events that could be going on, such as financial stress or illness within the family, those who are receiving very little support from their family or friends. A big risk is if it's an unplanned pregnancy, and again, being a single marital status, having low self-esteem, and history of trauma, whether that be sexual abuse, emotional, verbal, or physical abuse. Symptoms of postpartum depression can widely vary, but include frequent crying, sleep disturbances, changes in appetite, anxiety and panic attacks, agitation or irritability, an over-concern or a lack of concern for the baby, feelings of loss of oneself, intrusive, repetitive thoughts, continuously reliving past traumas, feelings of guilt and worthlessness, feeling overwhelmed and unable to cope, a loss of interest in things that they had previously enjoyed, and of course, fear of harming oneself or their baby. The etiology associated with perinatal mood disorders, including postpartum depression, can include hormonal fluctuations, a dramatic decrease in estradiol and progesterone, disruption of the neurotransmitters in the brain, including a deficiency of serotonin, and variations in the HTR2A gene, which is highly associated with postpartum depression. So this is a really good visual to give you an idea of what somebody with postpartum depression could be going through. They may have feelings of loss, so loss of control, loss of self, their relationship, loss of who they were and their voice. There's often a misconception between what they expected motherhood to be or parenthood and what the reality of it actually is. That can also include feeling judged by other parents or pressures from just cultural context. These feelings can build and there can be a spiraling downward with increased anxiety, feelings of overwhelm, obsessive thinking, anger, mental fogginess, feeling alone, guilt, and of course contemplating self-harm. Those who are brave enough to seek help for postpartum depression can make gains. They do have to surrender to the fact that they need help and need coping mechanisms. It can be a struggle for them to survive, and they need to find different ways to make changes to focus on regaining their mental health. The past few years with the COVID-19 pandemic, it has raised a particular concern with those who are affected or at risk for postpartum depression. There is more isolation and lack of social support. There's not as many people around as maybe you would have expected in the past to help you through those early stages of having a baby due to the social distancing. And there's a lot of fear associated with the risk of infection of COVID-19 and transmission to the new parents and also the baby. So it just adds an extra layer of stress to those people who are already having a really hard time. So I wanted to share some metaphors that have been used to describe the emotional feelings of those who are suffering from postpartum depression. They refer to these feelings as, or postpartum depression as, being a thief. They feel like an actor, a tightrope walker, a robot, like they're in the middle of the sea. They're a loner. They have enveloping fogginess. They feel like an alien. Their skin is crawling, like an erupting volcano, or like a ton of bricks. I wanted to introduce you to Juliana. Juliana is a 24-year-old Hispanic woman who had a vacuum-assisted vaginal delivery at 40 and 4/7 weeks gestation, and this occurred 6 weeks ago. She's now at her postpartum visit. Her pregnancy was complicated by gestational hypertension, which she ended up being induced for. She did receive an epidural for pain management during her labor, and she was augmented with Pitocin to establish adequate uterine contractions. She delivered a 7-pound, 12-ounce baby girl, Emery, who had APGAR scores of 5 and 8. Juliana had a 3rd-degree perineal tear that was repaired after delivery. She ended up having a postpartum hemorrhage, which was due to retained placenta that was manually removed during her recovery period, and her quantitative blood loss was 1,200 milliliters. She received tranexamic acid and oxytocin postpartum, administered per hospital protocol. Juliana has been breastfeeding, but she's struggling to maintain a sufficient milk supply. She's using a nipple shield, and Emery is always crying and hungry. So when you see Juliana, she reports, "I'm having a really hard time. I'm just so exhausted. My head hurts all the time, and I feel so worried that something bad is going to happen to her. Honestly, I don't even think I'm a good mother. She would probably be better off without me. I can't even get her to stop crying, and she never sleeps." You've reviewed Juliana's health history, and it's significant for past medical history of asthma, an abnormal PAP with HPV, anxiety, disordered eating as a teenager. She's a former smoker, and she had a COVID-19 infection during the pregnancy. Her past medical history includes a DNC in 2020. Current medications that she is taking are a prenatal vitamin. She's taking ferrous sulfate, Colace, ibuprofen, and an albuterol inhaler. She has allergies to penicillin. Family history is significant for maternal breast cancer, depression, and obesity, and paternally history of alcoholism, hyperlipidemia, and post-traumatic stress disorder. So her social history, Juliana lives with her boyfriend in an apartment. She's just moved to New Hampshire from Massachusetts in the past year due to her boyfriend's new job. She's a high school graduate, and she works as a hairstylist. She has recovered from an eating disorder as a teenager, and she has reported history of sexual assault as a teenager as well. Unfortunately, she has not made very many friends in the area as she's new to New Hampshire and it's a COVID-19 epidemic. So you carefully listen to Juliana's symptoms. I found this really great ad from the CDC about Hear Her. So to validate hearing her concerns after having a baby. And one of the things they talk about is the most basic tool, which is listening, can really save lives when it comes to pregnancy-related complications. So Juliana's symptoms that she complains of are fatigue. We could think, does she have possibly maybe anemia? This could also be a sign of postpartum depression. Low energy. She did have that postpartum hemorrhage of 1,200 milliliters, so that maybe could attribute to this as well. She's having chronic headaches. Another factor that we need to think about here is preeclampsia, because she was induced for gestational hypertension. Is she developing postpartum preeclampsia? Women or birthing people are at risk for developing preeclampsia up to 6 weeks after having had a baby. And she's reporting anxiety. So Juliana's head-to-toe assessment is primarily normal. We do note that her behavior is depressed. She's tearful and anxious. Her vital signs are normal. Blood pressure being 112/64. That kind of makes us think maybe this is not preeclampsia. She does not have a fever. Her obstetric assessment is normal. Her fundus is no longer palpable. Bleeding is normal. Breasts are full, and no mastitis is noted. So pertinent labs and diagnostic tests for Juliana would include some sort of a postpartum depression scale. One of the most common ones is the Edinburgh Postnatal Depression Scale, and I've shown you what Juliana has responded to these questions on the right here. It's a series of 10 questions, and it's been validated with a number of research studies, which has shown reliable measure of detecting depression during that postpartum period. A score of 10 to 12 is considered a cutoff for postpartum depression, and Juliana actually scores a 16 on this test. So it is apparent that she is suffering from postpartum depression. An important thing to note is number 10 on this scale is the thought of harming myself has occurred to me. If she had responded anything but 0, never, it would require an immediate follow-up or hospitalization because that would be a serious issue. So we know that she's suffering from postpartum depression. We also want to do a complete blood count to check for anemia. And we do see that her H&H is a little bit on the low side, 8.9 and 27.3. So that's something that we can consider. All other lab values were within normal limits. We also checked her thyroid. Sometimes the thyroid can be off postpartum and cause like a thyroid storm and have some similar symptoms to postpartum depression. But we found that her thyroid was within normal limits. So Juliana's differential diagnosis would be postpartum depression and also anemia, which is related to the postpartum hemorrhage. When we look solely at postpartum depression here, we know that Juliana has multiple risk factors for to have developed postpartum depression. These include that she is Hispanic, she is 24 years old, she's single, living with her boyfriend. She does have history of sexual abuse. This was a traumatic delivery. It was a vacuum delivery, and she also had a postpartum hemorrhage with a manual extraction of her placenta. We also know that Juliana is new to the area, and this could complicate her support system, and she may feel really lonely. So when considering interventions for Juliana and also for postpartum depression, there are multiple different things that you can try. One category would be psychological treatment, and this could include cognitive behavioral therapy or psychotherapy, which have both shown to be very beneficial for those with postpartum depression. And something that could be very helpful is just like the telehealth visits. So not having to physically go to an appointment to speak to somebody, or home visits. Some places actually offer home visits to postpartum parents to check in regularly, and this could also provide additional support. Early postpartum follow-up and frequent follow-up. So perhaps if we had identified Juliana as being at risk for developing postpartum depression before she left the hospital, we may have had her schedule a 2-week appointment as well, and possibly a 4-week appointment before her standard 6-week postpartum visit. Peer support is very valuable for people with postpartum depression, and just listening. People who are just going to listen to them talk about what's going on, or just sit with them, not give them advice necessarily, but just show their support. Another category for treatment would be pharmacological treatment, and the first line of defense is SSRIs. The second line would be tricyclic antidepressants, and of course we would want to just confirm that whatever is being prescribed to Juliana would be safe with breastfeeding her baby Emery. There is a new medication called Zulresso or brexanolone, and this is the only medication that's approved by the FDA that is specifically for the treatment of postpartum depression. And actually for moderate to severe postpartum depression, which Juliana may qualify for. This actually requires admission to a labor and delivery unit that is approved to administer this IV medication, and it's administered over 60 hours, and it actually allows for rapid improvement in people's mood, so within 72 hours. And I think the challenging thing with the SSRIs is that it can take time for someone to notice a change in their mood, like up 2 to 6 weeks. So this is something that can help a lot faster, and it has been shown to last as well. So it can kind of get them through that time where the SSRI starts to become effective. Some other non-pharmacological methods and alternative medicine therapies that have been shown to be effective for postpartum depression would be massage, acupuncture, and an omega-3 fatty acid supplement. So when considering resources and referrals for Juliana, we would want to give her a lot of different options. We would definitely encourage her to set up some time to meet with a mental health provider. In the Seacoast, New Hampshire area where Juliana is living, there's a really cool place called Relief Parenting Respite and Resource Center, which offers respite rooms for new parents. So you can go during the day and reserve a room, and like basically somebody will watch your little one and you can take a nap for like 60 to 90 minutes. It's really cool. There's also a lot of community support there and classes, so she could connect with other new parents and kind of have a little bit more social support. Also, a little bit outside of New Hampshire would be the Mass General Hospital Center for Women's Mental Health. They have a lot of online resources, and if Juliana was interested, she could partake in a various different number of research studies and different medical trials that Mass General and Harvard University are working on to support women's mental health after having a baby. And then there's also the Postpartum Support International online group, which has online support groups that meet numerous different times during the week, which are peer-led. And, you know, the first 30 minutes, they kind of talk about, they give information, they educate the parents, and the next about 60 minutes is more of just like a group talk where the members can just kind of discuss what's going on and just have others to be present and listen and just have a sense of community. But that is not for individuals who are feeling like this is a mental health crisis. And of course, in addition to the other interventions and treatments that we've offered to Juliana, we want to make sure that she is aware that there are crisis hotlines available if something changed. And it is important if you or anybody you know is having a mental health crisis that there is numbers that you can call for immediate help. 988 is actually a new hotline that just opened this past week, and you can get immediate counseling over the phone and just support. And we want to encourage Juliana to reach out, even if she just feels like things are a little bit heavy and she needs somebody to talk to. If Juliana developed feelings of wanting to harm herself or her baby, we would encourage her and her support person to call 911 and go to the nearest emergency room for medical treatment. There's also another National Suicide Prevention hotline that she could reach out to, which I included information for here. But it's really important that Juliana know that she's not alone and that things will get better. There's hope for her. And if she is really struggling, to please reach out and, of course, dial 988. The role of the advanced practice registered nurse in screening and assessing pregnant or postpartum individuals is to be sure to use universal screening. So asking everybody about their mental health every time. Some people can hide it better than others. In Juliana's case, she was open and honest about how she was feeling, but not everybody is. So definitely providing at least a mental health screening of some sort is very important. And knowing that it does affect 1 in 8 women, or birthing people rather. So it is the most common postpartum complication after having a baby. It's important to know the local resources, to know where to send these patients to for follow-up treatment and help. And we want to be able to really do a good job diagnosing, treating, if Juliana or another patient that we're seeing is agreeable to try medication, to let them know that it takes time, and to also be open and flexible to make changes if something doesn't seem like it's working for them, and frequent follow-up care. So whether that be via telehealth, if that's better for the individual, or in person. And on more of a larger role, the advanced practice nurse really needs to support the implementation of public health initiatives that raise awareness, help to remove and reduce the stigma and barriers that are associated with treating and diagnosing mental health, and also expanding the research that's associated with postpartum depression. So the biggest takeaway with this presentation and in Juliana's case is to really listen to our patients. And again, I just really love this campaign by the CDC, Hear Her. So hear her concerns, listen, ask everybody how they're doing emotionally, and really work to help remove the stigma surrounding mental health and offer support. Thank you.